Hi everyone, welcome back to my channel. Recently I did a literature review to look at the evidence supporting the new Ministry of Health Ontario guidelines on the expanded criteria for Paxlovid prescribing that was updated on December 8th of 2022. And I just wanted to share these findings with everyone here in this video. So to start off, let's look at Ontario Ministry of Health's new expanded Paxlovid criteria that they last updated on December 8th of 2022. According to this new expanded criteria, for those who are eligible for Paxlovid, Ontario Health states that Paxlovid should be strongly considered for individuals who have a COVID-19 infection that's confirmed on either a positive PCR, rapid molecular, or rapid antigen test, and present within 5 days of symptom onset with one or more of the following criteria. Of these criteria, they list that if you're 60 years of age or older, regardless of your immunity status or comorbidities, if you're 18 years of age or older and immunocompromised, or if you're 18 to 59 years of age and at higher risk of severe COVID-19 infection. And they define patients at higher risk of severe COVID-19 infection as those who have one or more comorbidity that puts them at higher risk of severe disease, or those with inadequate immunity, who are either unvaccinated or have an incomplete primary series, or if they completed their primary series and last received their COVID-19 vaccine dose more than 6 months ago, and or if their last COVID-19 infection was more than 6 months ago. I think there's evidence to support the use of those in those of 60 years of age or older, as we know that age is one of the risk factors for developing severe COVID. Where the contention or the controversy in the evidence lies, or where there's a discussion on whether there's enough evidence to support the expanded criteria, is in this younger age group, in those who are 18 to 59 years of age and a higher risk of severe COVID-19. And in this video, I'll highlight the evidence that look at with a focus on this younger age group to hopefully help you come up with a more informed decision on whether these guidelines are evidence-based, or if you think that there should be some clinical judgment on the use of Paxlovid. So to start off, let's look at Ontario Ministry of Health's new expanded Paxlovid criteria that they last updated on December 8th of 2022. I've summarized the evidence and the studies that I've reviewed in this note. Keep in mind that I did focus more on the younger age group, as this is where there's more controversy. So the selection of the study was more targeted to studies that have done subgroup analyses looking at younger versus an older population. I made notes on the studies that I'll go through in this video, but I'll also link you to these studies in the video notes below. To start off, let's look at the MMWR US study that was done in 2022. All of these are retrospective cohort studies done in an average of 100,000 patients that were prescribed Paxlovid in the databases in these different countries. So in terms of the MMWR US study, this was a retrospective cohort study done in the US in adult patients who are COVID-19 positive and are ambulatory or outpatients. 92% had at least one underlying condition. In those who received Paxlovid versus those who did not, they saw a significant reduction in COVID-19 hospitalization within 30 days in the whole subgroup. When they looked at the subgroup in those who are younger versus older, they found that this reduction in hospitalization was also significantly reduced in those of a younger age, so those 18 to 49. However, it was not significant in those with only one underlying health conditions and vaccinated with at least 3 doses of mRNA vaccine. The next two studies I'll talk about is the Israel study. There were some overlapping patients, I suspect, in these two studies because they both used the Clin Health Service database to extract the information in this retrospective cohort study. The only difference is that the 2023 study here also tapped into data in the Israeli Ministry of Health COVID-19 database and included patients who are 18 years or older, whereas the 2022 study only looked at those who are 40 years and above. And so overlapping patients, although the 2023 studies had more patients included. Again, a very large study of more than 100,000 patients in this retrospective cohort. In those with COVID-19 infection and also in outpatients, Paxlovid was prescribed in those with at least one comorbidity at high risk for severe COVID. And in the 2022 studies, they looked at the risk of progressing to severe disease using a risk score model that takes into account their comorbidity status, their age, etc. So between those who received between those who received Paxlovid and those who did not receive Paxlovid, they found that Paxlovid reduced COVID-19 related hospitalization in the 2022 study, but this was not statistically significant in those in the younger age group, whereas this benefit was seen in those who are older than 65. And again, when they broke it down by vaccination status for those who are younger, with the age of 40 to 64, there was no difference with Paxlovid use, regardless of their immune status, if they are of younger age. So that was hospitalization. In terms of their secondary outcome, they looked at mortality or death due to COVID-19. Again, they found that people who are older had a statistically significant reduction in death due to COVID, but this was not significant in those who are of younger age, in those who are 40 to 64. In the 2023 Israeli study, again, overlapping patients, they looked at the composite of severe COVID-19, and they defined severe COVID-19 infection as those with a oxygen saturation of less than 94% on room air, a PaO2 to fraction-inspired oxygen of less than 300 millimeters per mercury, or those with a rest rate of above 30, or COVID-19 related deaths. Again, they found that Paxlovid was better in the overall population. And when they broke it down into age subgroups, they found that this composite outcome of severe COVID-19 infection and or mortality was not statistically significant in those who are aged between 18 to 60, so the younger age group. They didn't see any difference. All right. So the Israeli studies didn't find a difference in COVID-19 hospitalization and mortality in those who received Paxlovid in the younger age group. Let's look at the other studies that we found. So the US did another study. This was a Colorado study done by Agarwal et al. And this was a retrospective observational cohort study conducted during the Omicron wave between March and August of 2015. They looked at adult patients 18 years and older who are outpatients with COVID-19 infection and a high risk for progressing to severe COVID-19 as per the NIH guideline. And patients who are defined as high risk of progressing based on the CDC criteria. And again, your usual factors, those who are older, those with comorbidities such as chronic lung disease, chronic kidney or liver disease, etc. So in those who received COVID and those who did not receive COVID, again, another large cohort study of more than 100,000 patients, they found that Paxlovid overall, again, was better at reducing all-cause hospitalization within 28 days of COVID-19 diagnosis. However, when they broke it down into their pre-specified subgroups, those with 0 to 1 comorbidity had no difference, whereas they found that Paxlovid was better in those with 2 or more comorbidities. The effects were similar amongst younger and those who are older. In terms of the secondary outcome, they also found that Paxlovid was better in terms of reducing 28-day all-cause mortality with a adjusted odds ratio of 0.15 that reached the point of statistical significance. So again, although they found that the effects are similar among younger and older age group and those who receive Paxlovid in terms of reducing hospitalization and death due to COVID. Keep in mind that Paxlovid in this cohort study were prescribed to people with risk factors for severe progression. So those with comorbidities and those of older age, and not just limited to their immunity status. The next study that I looked at was a Hong Kong retrospective observational cohort study that was also conducted during the Omicron BA.2.2 wave done between February and June of 2022. This again was primarily an older population study, as 85% of those included were above 60 years of age. They included patients who were 18 years or older, so again, adult outpatients with COVID-19 infection. And those who received Paxlovid in Hong Kong had to meet the following eligibility criteria. So they had to have mild symptoms, were at risk of progressing to severe disease. Again, we're looking at your typical comorbidities here and age to determine this, and within 5 days of symptom onset. In those who received Paxlovid and those who did not, they found that overall, all-cause mortality wise, Paxlovid was better. But when they broke it down to subgroups in terms of age, because 80% of the patients here were above 60 years of age, they did not have enough data to calculate a hazards ratio for those of a younger age group to give a result on whether the younger subgroup had significant reduction in mortality versus the older age group. So I think this study, again, putting into context of the question that we're trying to answer, shows that most of the patients were still above 60 years of age. There's not enough data to support the benefits of Paxlovid in those less than 60, as they did not have enough data to calculate a hazards ratio to see if Paxlovid really did or was associated with a reduction in mortality in the younger cohort or population. Lastly, we have the Ontario study. So this was a population-based cohort study done in Ontario between the time period of April to August 31st. They included patients who received Paxlovid who were adults, so 18 years of age or older, who were outpatients, and patients were eligible for Paxlovid via the prior Ministry of Health criteria. So these were the criteria prior to the December 8th, 2022 update, obviously because the study was done between April and August 31st. 80% were vaccinated with 3 or more vaccine doses. They found that in those who received Paxlovid versus those who did not, overall, again, in terms of the composite of COVID-19 related hospitalization or all-cause mortality within 30 days, Paxlovid was better in the overall group. However, when they broke it down to pre-specified subgroup, this effect was shown consistently across the subgroup. So for those who are younger, less than 70, to older, so 70 years of age or older, they found that the reduction in the composite of hospitalization and mortality related to COVID was similar. This was also statistically significant regardless of the patients or the people's immunity status, so regardless of their vaccine doses that they received, regardless of when they got their last vaccine doses, whether it was more than 6 months ago or less than 6 months ago, Paxlovid was still better in all of these subgroups that they tested. And Paxlovid was still better in those with, regardless of the number of comorbidities that they have, whether they had less than 3 or 3 or more comorbidities. Putting this into context into the question that we're trying to answer, however, the study, I think, supports continuing the use of the previous MOH criteria because the people who received Paxlovid here that they assessed were prescribed Paxlovid based on the prior MOH criteria and not using the new one. Looking at the entirety of the evidence, I don't think there is strong enough evidence to support the use of Paxlovid in those with COVID-19 infection and less than 60 years of age, or at least 18 to 59, as recommended by the MOH guideline. And this is summarized in the MMWR US study that found that there was no statistically significant difference in those who received Paxlovid versus those who did not in the younger age group of 18 to 49 with only one underlying health condition. Again, the 2 Israeli studies found that in those who are 40 to 64, so for those who are younger, there's no difference in COVID-19 related hospitalization or death due to COVID. The US study that was done did not find there was any statistical significance of COVID in reducing all-cause hospitalization in those with just 0 to 1 comorbidities. And the Hong Kong study didn't have enough data to support the use in younger patients, as 85% of those who received Paxlovid in this observational cohort were above 60 years of age. And the Ontario study gave COVID based on the old MOH criteria. So although the study found that Paxlovid was beneficial across all age group, across all comorbidity that the patients had, it still supported the use of the older criteria. With more and more pharmacists being able to prescribe Paxlovid in the community, I think it's very important that we all understand the evidence that our current provincial guideline stems from. I'll leave this video off with this commentary that was published by Wes, and I'll link you to the article notes in the video notes below. In this article, he talks about choosing wisely in who we prescribe Paxlovid to. I'll just highlight the last part in the conclusion, and I'll again link you to the article so that you can take a read yourself. So nowadays, as we all know, with the Omicron era having less severe disease compared to those of the Delta variant, and more of the population being vaccinated or having immunity to COVID, either because of vaccination or prior infection, this article states that we really need to weigh the risk and benefits of prescribing Paxlovid to patients and really picking those who are at highest risk of progressing to severe disease and who would really benefit from this therapy compared to the possible risks of drug interactions, having to hold their cardiovascular medications for a certain number of days while they're on this treatment, and the risk of side effects, and theoretically the risk of increasing or promoting COVID-19 resistance to this antiviral drug, Paxlovid itself. In conclusion, we want to choose very wisely who we prescribe Paxlovid to. We really only want to prescribe Paxlovid to those who would truly benefit from the drug, and the benefit would outweigh the risks of drug interactions, experiencing drug adverse effect, and theoretically increasing the risk of COVID-19 virus developing resistance to Paxlovid in the long run. Again, medical evidence, especially surrounding the COVID-19 pandemic with the evolving variants, change very rapidly. The last literature search that I did to compile these studies was done on March 4th of 2023. So if you're watching this video, very likely after this date, make sure you do your own review of the literature and the guidelines just to make sure that you're up to date with the most current evidence. I hope you found this video helpful, and I hope to see you in my next video. Till next time. Bye for now.